keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, my name is Dr. Vaskin Dilsizian. I'm Associate Editor of JACC Imaging. With me today is Dr. Henry Gwertz, who's Associate Professor of Medicine at Harvard Medical School, and he is the Director of Nuclear Cardiology at Massachusetts General Hospital. Henry, welcome.
Thank you for inviting me.
In a recent publication, you have introduced the concept of measuring absolute blood flow using PET imaging, using single injection with adenosine. And you compare that to traditional measurements of flow reserve and percent uptake as it's done traditionally with SPECT imaging. Could you tell us about your paper and what your findings were?
Sure, thank you. We basically did a retrospective study and looked at about 50 patients. About 1/4 or so had coronary disease, give or take a bit. And what we did is made three basic measurements. One was absolute myocardial blood flow with PET using N13 ammonia as the tracer. With the same injections, we were able to measure relative uptake of the tracer, and we were also able to compute the traditional flow reserve measurement because we measured blood flow both at rest and with adenosine stress. It was my thought and concept at the start of the business that the uptake and flow reserve measurements may not be good as the absolute measurement. Principally, as a physiologist, the heart lives on real amounts of blood flow and not on ratios. And as you had actually demonstrated a number of years ago, the uptakes may be a shifting target. So what we found after proposing the hypothesis that the absolute measurement would be best was something like as follows. The optimal cut points showed that sensitivity for the absolute flow measurement ran about 80% at specificity, 85%. Predictive accuracy also about 85%. The relative flow reserve was lagging only at 60% sensitivity. Specificity was comparable. Predictive accuracy was a little bit lower at 80% or so, and that was a borderline statistical significance in terms of being inferior to the absolute measurement. And then finally, uptake was last in the fleet. It was about 50% sensitive. Its specificity was comparable. Overall predictive accuracy was down around 60 or so percent. It was inferior to both.
It's interesting, when we do myocardial perfusion imaging, we think that we're actually measuring blood flow, but we're really looking at things in relative terms.
Yes.
And even with PET imaging, which is quite prevalent these days, most laboratories read images in qualitative terms, in relative uptake.
Right.
So what you are proposing is that we really should go beyond looking at tracer content or uptake.
No, sorry, I quite agree. I think that the major advantage with PET is that it is capable of being quantitative, which means you can get real measurements of blood flow. And it's important to use it to its full advantage. If you only take advantage of its attenuation correction capabilities but still read on a relative basis, there's important information to be missed and also the potential to mislead.
So your findings, again, using ammonia, PET, and adenosine, perhaps you can address whether this is generalizable to rubidium, to percentine or regadenoson, and how would someone actually, at the present time after reading your paper, apply this in their laboratory?
Okay, well, that's a lot of questions. I'll try and remember them all. With regard to rubidium, there are some publications out which indicate that there is a quantitative flow model. It's yet to be widely used and widely validated, but I would say that in the event that it does become better validated and more with greater experience in it, that the potential is there then to use the rubidium. Qualitatively, rubidium I'm mistrustful of because its distribution is clearly a function of time and myocardial viability, and depending on when it's imaged, one may acquire very different impressions. So rubidium may or may not work. If the quantitative model is good, it should work.
What about other vasodilators?
And the vasodilator point, I believe, is as follows. The regadenosine generally has been shown to be equivalent to adenosine. So as long as you can get the timing right in terms of getting that squirt of tracer in, it should prove satisfactory compared with adenosine. Dipyridamole, on the other hand, clearly the basic work shows that there's a larger spread of the vasodilator response to the drug, and the test depends on getting a near maximal dilator response. And so the concern about dipyridamole then is that the patient-to-patient variability is such as that you could be misled simply because of individual variation in the dilator response to that drug. I would not recommend using it for this.
So if I could summarize your finding, with single injection at a low radiation dose, if you quantify absolute blood flow, you were able to achieve higher sensitivity than to traditional markers of flow reserve
Yes.
or percent uptake when using coronary angiography as gold standard.
Yes, that's right, and I understand that that's comparing anatomy and physiology, but it's what we're stuck with at the moment. Hopefully we'll get to the day that the only need for anatomy is when you need to do an interventional procedure, and then you do need to know the anatomy. After that, what one is really interested in is how much can blood flow increase, and that's best measured with PET right now.
Dr. Gort, it's been a pleasure having you here.
Thank you. I've
admired
enjoyed
your
it.
work over the last several decades, both in swine animal models of absolute blood flow measurements, now transitioning to human models, and we look forward to subsequent papers to JACC imaging.
Well,
thank you very much for your tuning in to CDN.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.